This discussion is on Chapter 10, Mood Disorders, Mental Health Nursing by Cynthia Chinchillo. So let's take a look at what we mean by mood before we even go any further. So mood is an emotion that is prolonged and permeates the individual's entire psychological thinking. The feelings are changeable depending on the person's perception. For example, one individual might respond to a separation or a divorce with deep feelings of sadness, regret, and failure, while another might feel more contented, feeling relief and freedom. Woohoo! Right? Now, affect describes the facial expression an individual displays in association with the mood. So we would expect that an individual that's happy or excited to be smiling, right? If someone is unhappy or angry, they may be grimacing. Okay, so if a patient has what we call a flat affect, they are not showing any signs of emotion at all on their face. So we want to look at our mental health patient and we want to make sure that their mood and their affect are congruent. And really, let's focus on the affect for a moment. So if, for example, a patient is telling you, oh, my dog died, that's kind of a sad kind of situation. I wouldn't expect the patient to be smiling from ear to ear. And so we would say that that is incongruent with what you would expect to see. It's not the same. The situation and the affect don't match. So if someone says, oh, yes, I'm really excited I got this new job and they start crying, right? That's not necessarily congruent. So we have to find out, why is this patient crying or why is this patient smiling, right? That should be kind of like some red flags because they're describing a situation that under normal circumstances, most people would be either happy or sad. So we kind of have to pull the string and figure out why. Now, let's talk about euphoria. Euphoria is an excessive feeling of happiness. And so this is not just, okay, I'm super happy, I got a raise kind of thing. The thing that's scary about euphoria is it can escalate into mania. And when a person has mania, they are frenzied, they're unstable, they're out of touch with reality. And this is very concerning because this is when the patient is in mania, they can say, you know what, I'm going to fly, I'm going to jump off this roof and I'm going to fly because I can do it, you know. So they're really not with reality and they have feelings of grandiosity, feelings that they could conquer the world. And that is particularly dangerous. And again, remember, for the mental health nurse, our job is to keep the patient safe. Okay, so let's talk about depressive disorders for a second. Now, depression is described as a persistent and prolonged mood of sadness that extends beyond 2 weeks in duration or longer. Okay, so in the depressive disorders, there's a distinctive change in an individual's affect, right? How they're expressing their emotions on their face, and cognition, with the sadness being severe enough to interfere with the individual's functional activity. So, what does this mean? This means that your patient that is depressed may not be able to carry out their ADLs. They can't get up out of bed, brush their teeth, just take a shower, prepare a sandwich, right? All of these basic things can be affected. So our role as the nurse is sometimes, if the patient is severely depressed, is to step in and assist them with those activities of daily living until the medication and the therapy starts to kick in. In case you see any questions, that's going to be the role of the nurse, right? And of course, whenever we have a patient that is depressed, we are concerned about suicidal ideation, which is thoughts and suicidal attempts. Okay? Now, depressive disorders are referred to as unipolar, indicating that the individual does not experience episodes of mania. Okay, so specific types of depressive disorders include major depressive disorder, persistent depressive disorder, or dysthymic disorder. Okay, so let's talk about some risk factors for depression. Okay, so family history of depression. We know that there is a genetic link to these mental illnesses. We have prior episodes of depression is also a risk factor. Being assigned female at birth. What does that mean? Exactly what you think it means. Women, we are more at risk, biological women are more at risk for depression. Being in a postpartum period, right? There is postpartum depression, chronic illness, chronic pain, having experienced a major loss, a history of experiencing abuse, and having a substance use disorder. So these are all risk factors for depression. Okay. So let's talk about now bipolar and related disorders. Okay, so bipolar disorder is there's a pattern of mood swings. So this patient will be manic. They'll have euphoria. They'll be on top of the world, and then they will shift to being depressed. Right. So they go from very high to very low. Okay, and a lot of times there is a psychotic component that goes along with this. So we really, again, have to be concerned about this patient's safety, okay? Because when they are very high, they're high risk for cardiovascular collapse because they're moving and talking so fast that they will not sleep for days at a time. They won't stop to take food. So finger foods are going to be what we need to give this patient that's in a manic stage. A manic state, we need to give them high protein shakes because they need those calories. And we don't want them to take part in any risky behaviors like riding on their motorcycle in the rain at 100 miles an hour, right? So this is what happens, when your patient is in that manic state. Now, of course, depression, we always are concerned about the patient, what we call dying from sadness, which was dying from suicide. Okay, because the pain is so intense, so overwhelming, so excruciating that the only way to stop this pain is to end their life. Okay, and so that's really serious, and we have to take that very serious. All right, so when we think about now major depressive disorder, so this occurs when an individual experiences a depressed mood or loss of interest in most activities for most of each day for a period of at least 2 weeks. This can occur as a single episode or recurrent depressive episodes. So the persistence and severity of the symptoms during the major depressive episode help to differentiate it from that seen in other psychotic or delusional disorders. The depressive episode may have a precipitating circumstance. Something happens. Maybe it's chronic pain, the loss of a job, the loss of a support system, financial issues, conflict with friends or loved ones. So people who are timid and anxious, they tend to have more difficulty adapting to loss and with the increased pressures of life. So if they're shy, they're timid, they're really, having difficulties. Now, people that are bold and confident and easygoing, they have an easier time to adapt to these life situations. And we really want to, label that as something. It's resilience, right? So resilience. Okay. So recovery from the impact of these situations may precipitate depression and in those with inadequate coping skills. So that's a huge thing. So as a nurse, our role is to help our patient to develop these coping skills, give them the tools so that they're going to be able to cope with life because life is going to happen, right? We can't stop negative situations. We can't stop, bad things from happening. But what we can do is give the individuals, our patients, tools to cope with these situations. Now, when a patient has major depressive disorder, there is could be fatigue, appetite loss, or there could be emotional eating where they have weight changes, they have an increase, and they gain weight. So we have to look at that. So it's going to be either they can eat a lot or they won't eat enough, right? There's going to be an increase in their libido. They may cry, they may be irritable, they may have anxiety, they're worrying excessively. They have increased somatic symptoms, so those physical symptoms that we've talked about before. And they may have a lack of concentration, a difficulty making decisions. So, in your patient that has major depressive disorder, it can last for days, weeks, months. And so there's some ideas that is based on the neurotransmitters. We know that neurotransmitters are chemical messengers. So there's something going on with the brain chemistry. Okay, so it could be this major depression could be a sign or a side effect of substance abuse, medication, side effects, or even psychosocial factors. Okay, so let's talk about the signs and symptoms of major depressive disorder. So, mood of worry, anxiety, hopelessness, and worthlessness, guilt and self blame, crying episodes, fatigue, sleep disturbances, and anergia is A is without, and anergia is without energy. Anergia. They may have sleep disturbances, sleeping a lot, sleeping too little. They may have weight and appetite changes, decreased sex drive, that is the libido. They may have decreased productivity, difficulty making decisions. They may be irritable. They may experience extreme sadness with sad affect, physical complaints, anhedonia. So anhedonia is not getting pleasure from things they normally would get pleasure from. So maybe they really like to knit, to crochet, and they're not able to get pleasure from that. Maybe they really like to go roller skating, and they're not able to get pleasure from that. So decreased pleasure in things previously enjoyed, thoughts of death and suicide. Those are things that we really have to watch out for in our patients with depression. And of course, major depressive disorder falls under that. Let's talk about now persistent depressive disorder, which is dysthymia. So the individual with persistent depressive disorder, also called dysthymia, experiences a recurrent state of depression over a period of at least 2 years. Depressive symptoms become a part of the individual's day-to-day experience, never disappearing for more than 2 months at a time. The individual with persistent depressive disorder, dysthymia, has never had a major depressive episode and does not exhibit any symptoms of manic behavior. The symptoms of persistent depressive disorder, also known as dysthymia, are less severe than those of major depression, but the disorder tends to be chronic. Okay, so what does this patient with this persistent depressive disorder look like? Well, they may have chronic depression symptoms, feelings of inadequacy, failure, emptiness, hopelessness, learned helplessness, right? Which they get so used to depression symptoms, they begin to have a negative outlook and behave in a helpless fashion. They may have maladaptive coping skills, difficulty sleeping, increased or decreased appetite, fatigue, low self-esteem, difficulty concentrating, and decreased decision-making ability. So you all probably know the cartoon Winnie the Pooh. And so let's talk about the character Eeyore. Okay, so Eeyore, if you've ever seen the cartoon, he's just, woe's me, everything is horrible. Why are you inviting me to the party? I'm going to drag you down. So, I think of, depression, I think of Eeyore, I think of persistent depressive disorder, major depressive disorder, I think of Eeyore. So that's one of the, and I'll post this so y'all can see it, but that's one of the characters that definitely you can use to remind you of the signs and symptoms of a patient that has a depressive condition. Let's talk about postpartum depression, okay? Postpartum depression is seen in some patients after the birth of their infant. Postpartum depression is different than postpartum blues, also known as baby blues. Okay, so some people experience this after birth. Now, baby blues, that's a transition. That's going to, the patient may feel sadness and crying, and this may start about 2 to 3 days after delivery, but it doesn't last longer than 2 weeks. Now, that's important. That time frame is 2 weeks. Because remember, when that mom gives birth, she's changing hormones, her body is changing, she's not getting enough sleep, she's really worried about, okay, I have this tiny human that I have to keep alive. So there's a lot that goes into that. Now, that's baby blues. That's for the first 2 weeks. Now, symptoms of postpartum depression are the same as for other depressive disorders. It affects about 8 to 15% of those who are postpartum, and it can occur anytime from birth to 12 months after delivery. So, what are the risk factors? Okay. So, before I tell you the risk factors, I want to tell you that Chrissy Teigen, I hope I said her name correctly, John Legend's wife, she came forward and talked about her postpartum depression. Brooke Shields, she came forward and talked about her postpartum depression as well. And Chrissy really felt guilty because she was like, I have a nanny, I have help, I have a wonderful husband, but I just can't function. I can't get out of bed. I can't do what I'm supposed to do. Okay, so what are the risk factors for postpartum depression? Well, having a previous episode of depression, right? Maybe they have major depressive disorder, okay, or a history of postpartum depression. If there's a family history of depression there, that's a risk factor. Okay, if this was an unwanted or unplanned pregnancy, this is also a risk factor. If the patient is involved in intimate partner violence, that is a risk factor as well. If the infant is born with a serious condition, a life-threatening condition, or something abnormal about this newborn, maybe they have a congenital right from birth malformation. Maybe they were a preemie, they were premature. Maybe they had a miscarriage, or maybe they had a stillborn, or maybe they had a neonatal death, right? So these are all risk factors for postpartum depression. So as nurses, we've got to look out for these signs and symptoms. We've got to look out for, okay, is the mom bonding? Is the mom giving you those red flags that they say, you know what, I was thinking of hurting myself, hurting my children. We have to listen very carefully to our postpartum patients, okay, and provide them the resources that they need, okay? So when we talk about bipolar disorders, there is something that is going on. There's a chemical imbalance in the brain. Now, bipolar disorder is characterized by an atypical and erratic shifts in mood, energy, and activity. And so behavior, sleep, and as well as cognition. Now, these episodes alternate from manic, which they're high energy. I'm talking about they're just cranked up, right? They're euphoric. They can fly. They're the president. They can be the president. They know the CEO. They were a CEO, right? They're excessively happy, high energy. And then on the other end of the spectrum, they're low, depressive periods, and they may occur rapidly. And they may have intermixed with periods of typical functioning that occur simultaneously in a mixed episode. So since the individual exhibits both low mood, seen in depression, and then manic episodes, it's referred to as bipolar, having two poles or ends of the spectrum. Okay. So rapid shifts in mood in a short period of time are referred to as labile. And so labile, Labile, that's a term you need to know, labile. And if we say somebody's blood pressure is labile, you need to know that too, right? That means their blood pressure is really, really low or really, really high. And of course, that patient is unstable and shouldn't be assigned to the LPN, but you should still be familiar with that term. Okay, so labile means it's unstable, really high, really low. And in terms of the bipolar patient, we're talking about high mood or low mood. And so if an individual has 4 more episodes of mania or depression within a year, they are called rapid cycling. Okay. So bipolar disorder typically begins with depression accompanied by at least one manic episode. Okay, again, this is a mood disorder, right? This whole chapter is talking about mood disorder. So if your patient has full-blown manic episodes, right, they can't function. They have excessive activity. They're in a psychotic state. They won't sit still, right? They won't eat. You got to give them finger foods, give them high energy shakes so they can take with it when they're walking back and forth, right? They may have hallucinations, auditory. They're going to hear things that are not there, that's not external, which we call that internal stimuli. They may have internal visual stimuli, right? They may see something that's not actually there externally on the outside, and they will neglect their hygiene. Okay, so really important to understand how that patient will present. Okay, and again, we're always worried about cardiovascular collapse and their nutritional intake. Okay. Now, mild to moderate mania is called hypomania, and that lasts for a period of about 4 days. So they're cheerful, excessive energy with the ability to keep going long after others are exhausted. The need for sleep may decrease to 3 to 4 hours, and this may feel good to them, but later on, they can end up becoming irritable. They have impaired judgment and irrational thinking. Okay, so hypomania differs from mania in the length, the severity of the symptoms, and the level of impairment in daily life. The individual with hypomania does not experience psychotic symptoms of delusions or hallucinations. Okay? So something to think about with your manic patient is that they have this what's called grandiosity. Okay, this is larger than life, larger than reality, self-esteem, or feelings. They think they have more wealth or more intelligence than they really do. They have what's called delusions of grandeur. They are arrogant, they're boastful. I am the king, I am the queen, I can take on the world, right? So it's really important that we keep these patients safe. They shouldn't be signing any contracts. They shouldn't be making any large purchases like a home or a car or anything like that. That could be very dangerous. Okay. So also a patient that is in a manic phase may have delusions of persecution. They may be thinking that, you know what, people are out to get me. Okay. So we really got to pay attention to that in our patients. Okay. So let's now talk about cyclothymic disorder. This is a condition, and it's a chronic mood disorder. Remember, chronic is for an extended period of time, right? Long term, and is characterized by fluctuating periods of hypomanic symptoms and periods of depression. So they're hyper, they've got a little bit of mania, and then they have depression. The symptoms of cyclothymic disorder are insufficient in number, severity, or duration to meet the criteria for hypomania or major depressive episode. So this patient has the signs and symptoms of recurrent episodes of hypomania and dysthymia, states that they're not as severe, right, in bipolar disorder, short periods of normalcy, there's no psychotic symptoms, so they haven't broken from reality, and their functioning is not severely impaired. Okay, they're not severely impaired, and they don't necessarily need to be hospitalized. Okay, so let's talk about how we treat these depressive disorders or these kinds of disorders that make a patient sad. Okay, so we think about, again, with mental health, we have the pharmacological and then the therapy, right? So we have antidepressants, right? And antidepressants are used in the treatment of depression to elevate mood, increase physical activity and mental alertness, improve appetite and sleep, and restore interest or pleasure in the usual activities and things they've previously enjoyed. Okay, now because these neurotransmitters are involved in depression, they also affect other body functions. They can be used to treat other types of disorders, such as eating disorders and sleep dysfunction. As depression results from the decreased level of monoamine neurotransmitters like norepinephrine, serotonin, or dopamine, they're insufficient to stimulate the receptors. So most of the medications that are used to treat depression increase the amount of chemicals in the brain to help elevate mood. So that's important to understand. Okay, again, depression is because of a low level of these monoamine neurotransmitters like your norepinephrine, your serotonin, or your dopamine. So what happens is once we give these antidepressants now, there's going to be an increase in the chemicals in the brain, and this will elevate the mood. Okay, so that's going to be important. So we look at the different classes of antidepressants. We have monoamine oxidase inhibitors, and those are called MAOIs. We also have tricyclic antidepressants called your TCAs, and we have serotonin-specific reuptake inhibitors known as SSRIs. Okay, so something that's important to understand about these medications treating these depressive disorders, it's not like taking a Tylenol. You know, if the patient has a fever, you take a Tylenol, and in 30 minutes to an hour, the fever breaks. These medications need to be taken for at least a couple weeks, maybe even several weeks before the patient gets to a therapeutic level and they start seeing an improvement in their mood. Now, one of the things that you have to understand also is that not only does it take some time, the patient has to take it consistently, but we also have to monitor the patient that was once depressed for an improved mood. Because now this patient that was previously depressed, they didn't have any extra strength, right? They couldn't carry out the ADLs. Now they're taking this medication, they're getting their strength up. They may now have enough strength and energy to carry out their suicide plan. So we have to be very careful and monitor those patients. Okay, that's very, very important. So if they start giving away their possessions, that's a red flag. If they make statements like the world would be a better place without me, nobody cares about me, and I don't care about the world. Those are all red flag kinds of statements that you probably will see in your NCLEX questions, okay? So some things that are important about MAOIs that you should hopefully remember from pharmacology is the nutritional guidelines or restrictions. So patients that are taking MAOIs, a kind of antidepressant, they should avoid foods with tyramine, because if they're taking MAOIs and they have foods with tyramine, and I mean like your aged meats, your pepperoni, your salami, your chocolate, your avocado, your wines, those can have the patient go into a hypertensive crisis. This is a big NCLEX concept that you probably will see again and again. MAOIs, they need to, if the patient's taking MAOIs, they need to avoid foods with tyramine. Again, those foods are like salami, pepperoni, aged meats, cheeses, wines, chocolate, avocados. They need to avoid those foods. That's very important, okay? All right, so we talked about antidepressants. Let's talk about mood stabilizing drugs. The mood stabilizing drug of choice that you're always going to see for NCLEX is going to be lithium. Lithium carbonate is usually called lithium, and it's a naturally occurring metallic salt, much like sodium carbonate. It is used in the management of bipolar illness to both treat manic episodes and to prevent recurrence of these episodes. Lithium is more effective in treating highs, right, or manic periods than in preventing lows. So lithium is really important, and there's some nursing considerations when we talk about lithium. The big thing that we have to worry about is lithium toxicity, okay? So if your patient has lithium toxicity, they are going to have signs and symptoms that will tell you. So if you see a test question and they say the patient has a bipolar condition and they're taking lithium and then they go run outside in the hot sun between the hours of 10 to 2, that is a big red flag to me. I'm concerned about lithium toxicity because this patient's, number one, going to be dehydrated, right? So some of the things that we can see in a patient that has this lithium toxicity is arrhythmia, they can have bradycardia, they can have renal toxicity, they can have seizures, they can even go into a coma. So this is one of the things that you have to memorize, the lithium levels, right? So therapeutic serum levels of lithium is between 0.6 to 1.2 milliequivalents per liter. So 0.6 to 1.2, okay? So if you have a question and it tells you that the patient's lithium level is 1.5, boom, automatically I know that they're in the early stages of lithium toxicity. I'm going to hold the lithium. I'm going to notify the provider, notify my chain of command. That is a huge NCLEX kind of scenario, okay? So that's something, please, please, please remember that. If your patient is taking lithium, especially in the beginning, they will have frequent blood draws to monitor the therapeutic level or to see what the level of lithium is in their bloodstream, okay? So acute lithium toxicity is, they can manifest with tremors, headache, vomiting, confusion. They can have changes in their vision, seizures, kidney failure. So if the patient has dark colored urine and they're on lithium, you know that that's toxicity. Hold the lithium, notify the provider. So this is something you definitely have to know. All right, so let's take a look now at our next thing that's on the list. We talked about antidepressants and mood stabilizing drugs. I wanted to focus on lithium. Let's take a look. I think we discussed all the ones that I wanted to talk about. Let's take a look at the psychotherapeutic kinds of measurements to help our patients with these kind of mood disorders, okay? So again, when a patient has a mental illness, we are looking at medications and we're looking at some form of therapy. So they can have individual therapy, family therapy, group therapy. They can also have cognitive behavioral therapy. That's something that could be really effective for your patient. So when we think about cognitive behavioral therapy, we're thinking about structured, it's a goal-oriented type of psychotherapy, and it really works on the patient modifying their emotions, their behaviors, and their thoughts. We want them to kind of get rid of those negative behaviors, negative beliefs. So that's really intensive when a patient is doing this CBT or cognitive behavioral therapy. Okay, so psychosocial, again, we have to also look at the environment. Is this patient in an environment that is going to help them with their depression, or are they in a negative kind of environment that will actually prolong their depressive symptoms? Okay, let's talk about electroconvulsive therapy, that's known as ECT. So this is usually done as a last resort. And so the patient that is having ECT, we want to make sure that they are kept safe. And with ECT, what happens is they go in and there's electrodes that's actually placed on their scalp, and they are delivering electrical shocks, right? Electrical currents to the brain. And again, this is a last resort, and we want to keep the patient safe. And so after this, the role of the nurse, because the nurse is not going to be the one to deliver these shocks, but the nurse will be the one to prepare the patient to send them down to where they perform the procedure. And then the nurse will receive the patient when he or she comes back on the unit. The nurse's responsibility is to keep the patient safe and know that the patient may experience some memory loss, some confusion initially. So we really want to gently reorient the patient and keep them safe if they have an ECT procedure done. That's going to be really important. All right, so let's go to our next thing. So yes, antidepressants, they're meant to help to elevate the mood and improve sleep, appetite, increase those brain chemicals that help to make a person's mood elevated, but they're not curative, okay? So this is not necessarily the cure. So with the antidepressants, again, there's the three types, the MAOIs, the TCAs, and the serotonin. Okay, serotonin specific reuptake inhibitors, your SSRIs. We've talked about the MAOIs, and we got to be careful of those foods with tyramine. So that's going to be a huge NCLEX concept to know. TCA, we have to look out for arrhythmia, and we have to closely monitor. And I would tell you, if you have a depressed patient, that is a patient that you have to closely monitor anyway, because of the risk of suicide. Okay, your SSRIs have fewer side effects. Okay, so we use depressants not only for depression, major depression, but dysthymic bipolar disorder. We use it for depression with anxiety, as well as childhood enuresis. And enuresis is bedwetting. Okay, so that's important to understand. OCD. The patient may also receive antidepressant medications. If your patient has ADHD, panic disorder, and ADHD is a pediatric disorder, so that's what it means in the parentheses, right? And so it's not that it's a pediatric disorder, but only because there are adults with ADHD, but these antidepressants are given to children with ADHD, possibly, okay? Panic disorder, which we discussed in a previous chapter, bulimia, which is an eating disorder that is characterized by binging and purging, and then chronic pain. Now, contraindications for antidepressants, if someone, of course, is allergic to it, they have a hypersensitivity, if they're pregnant or lactating, and we want to be careful administering our TCAs, our tricyclic antidepressants, to patients that have just they post-MI, they've had a heart attack, if they have urinary issues like urinary retention, if they have benign prostatic hypertrophy or hyperplasia, they have an enlarged prostate, we're not going to give those medications, those TCAs. If the patient has glaucoma, we're not going to give TCA. If the patient has asthma, we're not going to give TCA. If they have hepatic or renal disease, hepatic meaning the liver, renal, kidney, we're not going to give TCAs. Okay, so when we treat patients that have mood disorders, we're not only going to use medications, but we're going to use, again, therapy. Okay, that's going to be what we do. It's a combination. We never have our mental health patients and just give them meds. We give them medication as well as therapy. That's a reoccurring theme that you should see. Okay, we talked about lithium, right? It's really effective more so on mania, not necessarily on the depressive side. Okay, and then we can use lithium also as an anticonvulsant. So when we think about, okay, how are we treating these depressive disorders, particularly, with these antidepressants, we're treating bipolar, we're treating also sometimes convulsions, and your patients should not receive these medications if they have a hypersensitivity, if they're allergic, if they have cardiac or renal disease. And this medication we're talking about is lithium. Okay, so on this particular slide, we're talking about lithium. So it's not for pregnant patients, those that are lactating, and those that have urinary issues or liver issues, and those that have seizures. We should be very cautious in using lithium. Okay, so when we think about the nursing process, that's ADPI, we want to think about how, when we assess the patient, what is this depressed patient going to look like? What is this patient with a mood disorder going to look like? What is their affect going to be? Okay, so mood is subjective, but we have to look at the patient and be able to understand, okay, this patient is manic. They are going on and on and on. They're not even taking a breath, right? So during mania, thought process become faster, they become fragmented, there's disorganized speech, right? So all of these things, when you're assessing your patient, you're looking at your patient, how they're dressed, what is their hygiene like? So you're assessing all of these things as you are interacting with the patient. And we're looking for, okay, how are we going to treat this patient? Now, we have to also think about the nursing diagnosis. And again, safety, safety, safety is going to be important. We think about the outcomes, right? The planning and the interventions. Let's talk about some of those things. If we have a depressive patient, right? If they have a depressive disorder, whatever depressive disorder they may have, we want the patient to have increased energy level. Another goal is identify their personal strengths. We want them to identify positive coping skills they can use. We want them to express decreased feelings of self-blame and doubt. We want them to openly express their feelings related to loss. We want them to participate in at least 2-unit activities per day. So we want them to become active, right? And that's going to be really difficult for your depressive patient. We want them to reframe their thoughts and change their negative thoughts into positive thoughts. We want them to be able to perform their ADLs independently. So these are just some common things or common goals or outcomes for your patient that has a depressive disorder. What are some of the things that we want, or some of the outcomes that we want for a patient with mania? Well, we want the patient to be able to demonstrate self-control, appropriate boundaries, physical boundaries with others, demonstrate decreased agitation. We want them to be able to verbalize their feelings in an appropriate manner. Decreased activity level, right? Not pacing back and forth, running around the milieu. We want them to consume at least 75% of each meal, right? Because again, we're always worried about their caloric intake. They're burning these calories because they're moving so fast, and we're worried about cardiovascular collapse. So we want them to have at least 4 to 6 hours of uninterrupted sleep. So I know in med-surg, you probably have, learned this concept already, that we don't want our patients to take naps during the day because that interrupts their sleep cycle at night, and that's true. However, the manic patient is the one patient that I say, look, if they're taking a nap, don't wake them, okay? Because sometimes these manic patients will not sleep for days at a time. So if they are taking a nap, please let them take their nap. Let them get their 4 to 6 hours of uninterrupted sleep. We want this patient that is in mania to be able to verbalize realistic expectations of self, and we don't want them to have hallucinations or delusions. And of course, when we evaluate these patients, that's what we're going to be looking for. All right, so here's the bipolar. Again, we also are concerned about suicide prevention. We want to keep those patients safe. Okay, so here's question number 1. So tell whether the following statement is true or false. Individuals with bipolar disorder experience symptoms of both mania and depression. Take some time, stop the video so you can check your answer. All right, so it is true. Those with bipolar disorder have moods that range from high manic episodes to low depressive periods. All right, let's go to question 2. A marked decrease in energy is also called anergia, anhedonia, okay, dysthymic disorder, or negativism. Take a moment to stop the video. All right, so it's A. Anergia, A is without, energia is energy. Anergia is a noticeable decrease in energy level, which may make a person depend on others for basic needs. Okay. All right, question 3. Tell whether the statement is true or false. Psychotic symptoms are a sign of cyclothymia. Pause the video and determine your answer. False. A person with cyclothymia does not have psychotic symptoms. That's really important to note. A person that has cyclothymia does not have psychotic symptoms. Okay, so remember, cyclothymic disorder is a chronic mood disturbance characterized by fluctuating periods of hypomanic symptoms and periods of depression. Okay, so that's what cyclothymia is. And so they will not be psychotic. They will not have a break from reality. They will still probably be able to function. They won't need to be hospitalized. All right, that concludes our discussion of Chapter 10. Thank you for your attention, and remember to always think like a nurse.